So, oh, Kathy, right, you were going to get us started off. Sorry about
Well, you can
that.
just keep on going, Kent. That's totally
I'm so
fine.
used to running these things, I forgot.
Well, for those of you who don't know me, my name's Kathy, and I am the executive director for the Red Willow Learning Center here in Missoula, Montana. And I was approached a few months ago, actually now, to be a partner in bringing this film and this Q&A this evening to Missoula. And I was just really struck by the relevance of the film itself, and certainly the potential for working with chronic pain. So I was absolutely delighted to be here this evening, really interested. And I'm going to turn this over to Kent, who is, what was the correct term? Filmmaker. I asked him if he should be a director or a producer, and he said all of the above. So filmmaker is what we settled on. So Ken, take it away.
Thank you, Kathy, and thanks to
Yeah.
the Red Willow Center for hosting the screening, presenting it to your group, and thanks you all for being here tonight. My name's Kent. I'm one of the filmmakers for This Might Hurt, and I'm going to introduce our panelist. So Dr. Becca Kennedy, MD, grew up in Ann Arbor, Michigan, and attended medical school at the University of Michigan and did her residency in family medicine at OHSU in Portland, Oregon. Becca worked as a migrant farm worker clinic for 5 years doing full scope family medicine before joining Kaiser Permanente 14 years ago. She worked in different capacities there, including primary care, urgent care, and an emergency department. Currently, she treats patients with chronic pain in the integrative clinic and is part of the long COVID specialty group at Kaiser Permanente. So, Becca, thank you so much for being here tonight. So I think it's really special to have you for this conversation because, you've been a medical doctor for 20 years, but only in the last year or so did you start incorporating these insights about mind-body health and neuroplasticity for brain retraining for these type of syndromes into your practice. And so I was curious to ask you, what has that been like?
Yeah, well, thanks. And it's great to be here. I appreciate everyone having me. And yeah, it's been very, very exciting. Probably 5 years ago, maybe 15 years into my career, I was seeing so many medical problems that our traditional medical paradigm was not able to help. And I just thought there must be other information out there about how we can help in a different way. And there's so much that goes on that it seems very clear that there's some sort of mind-body connection there, but just our traditional model of, as a physician, we say, oh, your body's okay, it's anxiety or stress, go to mental health. But then in mental health, they have crushing chest pain and they send the patient back, but no one's really connecting the dots of the two. And so mostly patients are sort of caught in this chasm. And so I just really looked at what other information was out there. And I actually started at Harvard has a Mind Body Institute that's been there for 50 years, that was started by a cardiologist. And they've done really great work around the stress response and a lot of work around how meditation calms our nervous system and other tools, and have a great program. But I started working with patients with a little bit, but I found that it wasn't quite enough, just doing those pieces of it. And then I found the work of Howard Schubiner that the movie is about, and about a year ago, and really just immersed myself in learning about this system and this idea. And it really, there's kind of just a deeper level of understanding the danger signals that a brain sends down, that those are the reason for the symptoms, and then how to turn those off. And so I started working with patients at the beginning of the year, and I am inundated by patients at this point. They're coming out my ears really, and every day I have this conversation. And And it's been really, really exciting, and it's really actually rejuvenated my my passion for working with patients, and have really seen some incredible changes in patients that have had symptoms for years and decades and have not been helped by any other way, any specialists or other doctors or pain specialists or mental health. And so it's been really exciting to put these pieces together and work with patients.
Wow, that's really amazing. And it's so cool that you've been able to, you have 20 years of momentum doing things the way you've normally been doing them, and then to suddenly like really make a pretty significant shift. Can you talk about if there's been like growing pains or difficulties with doing that?
Yeah. I mean, that's
And the
hard. It was
positive side
hard.
too, the
No,
good and the
right.
bad. Can you
Yeah,
talk
no,
a
I
little
mean,
more
it's
about
really
that?
hard. I mean, I have to say there was definitely times that I literally was thinking to myself, oh my gosh, am I in an alternate reality? And like even literally thinking, am I really telling patients this? Am I really saying that your emotions are in your body and we need to get them out, and that's what's going to solve this pain that you've had for 20 years? But it was really so it was really hard, and it then in my busy life trying to just learn everything I could about it was hard. I literally would be brushing my teeth at night, like looking at some sort of video to learn more information and just cram it all in my head. But I think that it ultimately made so much sense. And then when I would actually be questioning myself at the beginning, I just would have so many patient experiences where I would explain the model. And I would say, I mean, just out of the top of my head, maybe 50 to 60% of people, when I explain the model, they're with me and they just say, oh yeah, that makes so much sense. I get it. And then there's certainly people that are not with it at all and not interested, and it doesn't make sense. And then, a goodly amount of people that it makes enough sense that they'll stick with it, but they don't just embrace it right away. But I think I have so many experiences with patients, I mean, on a daily basis, that it really made sense to them. And they were so thankful to have this information that is kind of what kept me going at the beginning. And then now really seeing the outcomes and seeing the benefits of people getting better on the other side of it. It's really been great.
Yeah, that's so interesting because you get when you start talking to different physicians in the world who have all these different perspectives on chronic pain, you hear a lot that the people who are in our film who go to see somebody like Howard Schubiner, they're very self-selected, and that this represents less than 1% of patients, they'll say that have this kind of a mind-body thing,
Right.
of people with chronic pain like that. And then when I hear a story from you where you're saying 50% of the people, these are the people that you've selected as being relevant for, but 50% are really open to this and it makes sense to them. That's pretty dramatic. What's your perspective on that in terms of, is this a really widespread problem, or is it more like 1% of people with chronic pain?
Oh, no. I think it's widespread. I mean, I think everybody probably in their life have had at some point some sort of mind-body symptom. I mean, whether it's a tension headache or low back pain or, whatever it is, or an upset stomach, is mind-body symptoms. And very, very common. So I do this integrative medicine clinic where I do this specific work, but I also still work in primary care. I just kind of do like same day appointments. And so I see a lot of acute symptoms. And so I have this, I have this conversation, I don't know, probably with 3 new patients that are just coming in for whatever reason every single day of every clinic that I do. And I think there's even more that it applies to, but it's all, kind of what's been going on for them is so ingrained that it just is too hard a problem to get in there. But no, I think it's really very common for sure.
Okay, so could you, introduce us, so one of the things that Kathy was hoping we would talk about is, how the film is all about chronic pain, but the model of emotional awareness and expression therapy is not just relevant for chronic pain. It's often used for a whole array of other, what they call neuroplastic symptoms, let's say.
Mhm.
And so can you talk about how this treatment model is relevant for non-pain conditions like anxiety, depression, fatigue, insomnia, brain fog, those kinds of things?
Yeah, right. Yeah, and I treat people. I've successfully treated a woman in her 70s that was just overwhelmed with dizziness. And I've treated itching, feeling of bugs under the skin that someone had had for 2, 3 years, and lots and lots and lots of different symptoms. But it's really all about, and this is what I say to people too, is that, like I tend to say, what your diagnosis is being a human being. It's not that you're crazy. It's not that you're mentally ill. It's not that you're weak or, all these different things. I mean, this is how we are hardwired and are designed. And it's all about our threat system, and our brain. All it cares about is keeping us alive on this planet. Doesn't even care about the enjoyment on this planet. It just wants to keep us alive on this planet. And so our unconscious brain that runs almost all of it, our conscious brain is just this little tiny bit along for the ride, but our unconscious brain is constantly taking in all the sensory information from the world, as well as all the information from our body that our nociceptive fibers are constantly sending up to our unconscious brain to check in about what's going on. And it takes all of this information and it decides, is this dangerous or is this safe? And that's how we're redesigned. And it really just cares about what is danger. And then it stores and remembers everything that happened throughout our entire life when we were unsafe. And it uses that history to then apply it to the current moment of how it's interpreting the signals, which is why our brain is primed for interpreting the signals as danger if we've had more stressors and capital T trauma or little t trauma. And so our brain is then more likely to interpret signals coming in as danger, and whether that's from the body or from the world. And when our brain has decided that there's danger from whatever signals coming in, the danger part of our unconscious brain is turned on. And when that happens, our prefrontal cortex, what makes us human, the rational problem-solving part of our brain, gets shut down. So then when our danger part of our brain is turned on and our rational brain is turned off, then all these signals are more likely to be interpreted as danger. And then all we can see is danger. So this whole threat system then can lead to all of those different things. It can lead to anxiety and depression. And really at this point, what I look at, and maybe everyone here won't necessarily agree, but I think that a lot of the mental health diagnoses are really a lot of this threat system, rather than kind of this particulars about, is it OCD or ADHD or anxiety or, depression. Is that I think it's all sort of different manifestations of how the threat system works and how our brain is interpreting signals. And so if we can, and interpreting signals can also mean the information coming up from our body. So those signals can also be pain, and our brain misinterprets it and says, oh, that's dangerous, and sends down the pain signal, or dizziness, or GI symptoms, or tingling, or numbness, or, lots and lots of different things. And so at the root of it is really understanding the threat system in our nervous system. And if we can calm that down, understand what the threats are, teach our brain a new message that these things aren't really truly dangerous, then it can calm down those signals. And then it opens up our prefrontal cortex, the rational problem-solving part of our brain, which is the positive part of our brain. And then it interprets signals coming in from the world and from the body from a different perspective.
Thanks. That makes a lot of sense. It's a very, we're talking in like theoretical terms, and I was hoping we could kind of humanize this a little bit. And maybe there's a particular story you could share about working with somebody. It can be about pain. It doesn't need to be about one of these other things, like where you can kind of show what the work looks like from day to day, because the treatment has changed and evolved a little bit since we made the film, and each clinician kind of focuses on different things, and each patient needs different things. I was just curious if you could talk about some of the work you've done with someone.
Yeah, for sure. And yeah, exactly. There, I think everyone has their own sort of brand or style of how they do this work. And how I explain it to patients is I think about it in 4 different categories in terms of the treatment. And so the first category is understanding that the body is healthy. So like Dr. Schubiner, like with pain, for instance, like Dr. Schubiner was talking about, is that their body was healthy, is that like the patient with abdominal pain, for instance, or the hand pain or the leg pain, is that part of the body is healthy. And so I describe it like if you're afraid of heights, is that your brain has determined danger. So when you go to a height, it's a conditioned learned response in your brain that you're in danger. And so it sends warning signals. So if you're afraid of heights, it might be, feelings of anxiety and your heart going, or maybe dizziness or tingling or sweating, maybe a stomach cramp, maybe a headache. All of those symptoms, there's nothing structurally wrong in that part of your body. There's no disease or damage, but you're having those symptoms. They're very, very real and can be very overwhelming, but those are danger signals sent down from your brain. So in the same way, chronic pain and chronic other symptoms or anxiety is the same way, is that it's the danger signal that's sent down from the brain that's stuck in place. So it's really important to understand that the generator of that pain is not from the body. It's from the brain, deciding that there's fear and there's danger. Sometimes we have pain because the generator is from the body. If we break our arm, the information of that tissue damage goes up to our brain, and our brain sends back down the danger signal because of the tissue damage. So that's one way, but that's the structural way of having pain. But when it's been, we've evaluated, we've done tests, we've examined, we look at, physiologically that there is not a structural generator of the symptoms. It's from the fear in the brain. And that's really important to understand. Number one is that the body is healthy. And it is so hard to really get it and grasp it. I mean, I've had chronic pain myself. And, you move a certain way and there's like this super sharp pain. And you're like, oh my gosh, that feels so structural. And even me knowing this information, it's really hard to know, to really grasp it. But that is how our brain works. So anyway, number one, understanding that the body is healthy, that it's a faulty danger signal sent down from the brain as protection. Number two, the normal stress management tools, things like meditation, like what Howard Schubiner did. And all those normal tools, probably everyone knows the meditation, sleep, healthy eating, social connection, exercise, kind of all those normal tools. What they do is they turn down the danger part of the brain, turn on the rational prefrontal cortex, and calm the nervous system, the fight or flight part of the nervous system. When you do that, it is not turning off that danger signal. Is really important to understand, is that they're different mechanisms. So those tools by themselves often aren't enough, but they're really important, because if we're up in fight or flight, then our brain is more likely, again, to interpret signals as danger. So if we can bring down our nervous system into the relaxation response, then our brain is more likely to interpret signals as safe. And we're trying to get to safe signals. So that's number two. But the third and the fourth category that I talk about, the third category is the pain reprocessing therapy. And in the movie, I think Dr. Schubiner didn't do this part so much, but this can be a big part of it these days. And what that is teaching the brain safe signals while it's experiencing the pain. And so it's teaching the brain to actually turn off that neural circuit that's sending down the danger signal. So again, I explain it sort of like exposure therapy for fear of heights, is that it's a conditioned learned response that there's fear. And so when you're exposed to a height, then the brain sends down the danger signal. So exposure therapy is that you would be at a height and send your brain safe signals. You wouldn't go to a huge, huge height at the top of the Grand Canyon looking down 1,000 feet, because that's too overwhelming and the symptoms would be too big. So you would just start slowly, like maybe stand on a table or look out a window, and send your brain safe signals at that time when that danger signal is in place. Because the thing is that it has to be in place in order to bring in new neural connections to change it. It's sort of like if Kent were afraid of heights and we're just sitting here safe, in your chair, and I say, you really don't need to be afraid of heights. You're really not at danger. There's glass there, you're fine. I'm just talking to his conscious brain. And his conscious brain doesn't have direct connection to the unconscious brain. And the conscious brain is not what's involved. It's what the unconscious brain believes. So that's why just telling him is not really going to do almost anything. It's that you have to experience it, have the neural connection in place, and while that's there, you send your brain safe signals. So it's the same thing with a pain. And one of the ways of doing that is, say you had pain in your shoulder, like every time you moved it like this, you had pain in your shoulder. Is so what you would do is move it just a little bit. So there's a little bit of pain, and then bring it back down, and then focus your attention on safety. And maybe something in your body where it's feeling good, and focusing on that, or maybe focusing on safety in some other way, maybe even looking at a great image of a vacation spot you love, or some other safe signals, or breathing easy, but that you're sending your brain safe signals right with experiencing that symptom, but not when it's too bad. And by doing that as a process over time, you slowly teach your brain that it no longer needs to be afraid of that thing that's happening in your body. And it's a bit of a trick, because you're really trying to disconnect the fear that your unconscious brain has with experiencing the symptoms. So doing that pain reprocessing therapy in the moment, the purpose of it is not getting rid of the symptom in the moment. The purpose is actually experiencing the symptom a little bit and sending safe signals. And the symptom is going to be there. And when it comes and it's really big, just learning to sort of have like the mindfulness about it and recognize this is not dangerous. It's uncomfortable. Yeah, I don't want it, but it's not dangerous. My body is okay. And by doing this whole process kind of little by little over time, it slowly turns that circuit off, and it teaches the brain new information, if that makes sense. That part, I think, can kind of take a little bit to wrap your brain around, and kind of all the different pieces of it. But then the fourth piece, so understanding your body is healthy, it's a faulty danger signal, stress management tools to bring down your nervous system, pain reprocessing therapy to teach your brain to turn off the neural circuit, and then emotional work. And I generally say, in my experience, which is not super vast, but is that I think the emotional work is not 100% necessary for 100% of people, but I would say most people it is. And I've had so many conversations with people that have said to me, oh, I've dealt with my trauma. I've had therapy for years. I've really dealt with those issues. I really I don't think that's a problem. I don't feel angry. I don't, it's totally fine. And then when we start delving deep, it's there and needs to be dealt with. And it's under the surface, and it's not in part of the conscious awareness. And so I think that it is much more important and for more people than I think most people realize. But again, the way that I explain it is that, again, our subconscious brain, all it wants to do is keep us alive and safe on this planet. And sometimes that's because of a physical threat, but more often it's because of emotional threat. And when our brain learns that our emotions and our thoughts and our worries are too dangerous for our conscious awareness in trying to keep us safe, it will tuck them down, deep down where it believes it's keeping us safe, and keeps it away from our conscious awareness. And often this was really necessary for a lot of people. This was what we learned often as kids. And it was an important tool, and it did keep us safe. And when kids are either, not treated well by parents or caregivers, or even if, in my case, with well-intentioned, Midwest parents that just didn't know how to make an emotional attachment, is, whatever it is, where the brain doesn't learn that it's safe to express these things, then it learns to keep them down. So it's a normal human reaction to feel angry when we're not treated in the way that we should, but it is not safe to express anger as a child to a caregiver. Or someone might see that adults in their life or kids in their life or other people in their life express anger in a really unsafe way. They scream and yell or do unsafe things. And so again, that brain learns that that emotion is not safe to express. But emotions are not something that we rationally, consciously decide to have. They're part of our emotional brain. It's just part of being human. They just come about. They're just there. And that's how we're designed. And it's okay. And it's normal. And often it's justified. But what happens is that when our brain pushes them down and keeps it away from our conscious awareness, what ends up happening is it comes out through our body as fear and symptoms. And it can be stuck in our body for decades and decades and decades. And sometimes it's clear that it's from childhood. Sometimes it's not from childhood. Sometimes it's from our adult life. And maybe it harkens back to something that it happened as a child, or maybe personality traits as a child, that we always put other people first and we're a perfectionist or whatever it is. But, it's all complex, all those different parts. But in teaching our brain that it's okay to have these emotions and thoughts and worries, and they're just thoughts and they're not dangerous, in teaching a process for our brain to bring it up to our conscious awareness, give it a voice, let it say what it needs to say, but in a safe way, we release that and really teach our brain that we're okay, that wasn't dangerous, that we can do this in a safe way on a regular basis. And so, for instance, there's different ways to do this, but, some of the ways is expressive writing, and which I have a lot of my patients do, which is stream of consciousness writing. You just write whatever comes to your brain because you want to get down and get into the unconscious brain, into the emotions, thoughts, and worries that it believes are too dangerous for the conscious awareness. And then you get rid of it at the end. You rip it up, burn it, put it in the bottom of the garbage, take the garbage out, because you want to make sure that the brain feels safe, that it knows no one else is going to read this, or you're not going to read it again and perseverate on it. And if the brain doesn't fully believe that, it's going to hold back, and you don't want it to hold back. And it's a really powerful way to really start just getting those emotions and thoughts and worries out regularly. Another way is, one of the ways that Dr. Schubiner does, is the more kind of one-on-one emotional awareness and expression therapy. And that's something that I do, that I learned from Dr. Schubiner in clinic, where it's kind of similar to the expressive writing, but I talk people through it. And I talk people through, I have them talk about a conflict, and it might be something from childhood, it might be something from yesterday, from last year. And I have them describe the conflict, and then I work them through the process of allowing themselves to feel that emotion. And I connect up the physical symptoms that they're feeling and that emotion coming out through their body. And instead of having that physical symptom, just really allowing them to feel that emotion, say what it needs to say. So if it's anger, for instance, say what that anger needed to say, but it's just us. It's just in the exam room. It's not, we're not actually going to tell that person the angry thoughts. We're not going to punch them in the nose. I mean, that's not safe. We're just letting it out in that way. And then also seeing what other emotions are on the other side of it. And so, for instance, I did this with a patient the other day, a man like in his probably 40s or something like that. And he had a father that was just not very nice to him and didn't support him. And it was always mean to him when he messed up. And so he was teaching him to drive. And I mean, this was like the first lesson in the car. And he didn't know how to drive. And his dad was being sort of condescending to him that, oh, I didn't know how to do this and all this stuff. So we had him bring that up and really say to his dad what he would have liked to say, or, you know, being an adult, looking back in on him as a child, what he would say. And it was really interesting, I think, his perspective, because what he said to me is, before we did this therapy, he felt really sad about this situation with his dad, but he felt sad as a victim. And then after he did this, he said, I still feel sad because it sucks that my dad was like that. That's not changing. But I feel sad now in a much more powerful way. I don't feel sad as a victim. I just feel sad that that's a bummer. That's a bummer my dad was like that. And I went through that, but in a way that it didn't necessarily have to then change his lens about how he viewed himself and the world. And I mean, not to say that this one, you know, treatment changed everything for him going forward in his life, but I think that that's sort of the idea of really kind of expressing those emotions and really realizing our humanity in it. And then also recognizing that the sadness that he had after this was really because of love and compassion, and that he loved his dad and he has compassion for his dad and understanding the things his dad went through and why his dad was that. And I think that sometimes, especially with an emotion like anger, is that we learn that we can't simultaneously have love and compassion for someone and be angry. So we push it down and keep it away. But again, really learning that we are complex emotional beings, and it is okay to have all of this. And we can learn again to express it in a safe way so that it's not so overwhelming and coming out through our body.
That's great. That was very comprehensive. Dr. Kennedy, can you mentioned pain reprocessing therapy, and I'd like to zero in on that a little bit more. Do you think you could like guide what a typical somatic tracking of sensations in the body might be like when you work with a patient?
Yeah, for sure. And yeah, so let's go through it. And, you know, if anyone wanted to do this in themselves while I'm doing it. But what you want to do is, what I have people do is, and maybe as Ken, I'll say this to you, like I'm
Yes,
saying it to you.
I'll be the
You be
pain
the guinea
patient, and we
pig,
can
and
do a
then
role
if anyone
play.
else wants to close their eyes and kind of look into their own body and just explore around, you know, you're certainly welcome to do that. And again, let me know if any questions come up. But so Ken, what I'm going to have you do is I'm going to have you close your eyes if you're comfortable doing that, or just gaze down. And I want you to start relaxing your body. And I want you to breathe in through your nose. And then I want you to breathe out through your mouth. And I want you to breathe out a little longer than you breathe in. And just keep breathing in that way. Because again, when we breathe in, that actually turns on the fight or flight part of our nervous system. And the breath out turns on the relaxation part of our nervous system. So I want you to keep focusing on breathing out a little bit longer than you breathe in. And then I want you to just start exploring your body. And if there's a particular place that you've been having pain or having a bothersome sensation, you can go straight to there and start exploring. Or you can also just kind of start throughout your body and start at your head, go down to your shoulders, go down to your torso. And what I want you to do is I want you to think about that you're just looking at what sensations are there in your body and just observe those sensations with unemotional curiosity. You're just curious. Well, what is there? Where are you having sensations? And you're just a casual observer. You're laying on the grass, you're looking up at the sky, you're just noticing the clouds pass over and the different shapes of the clouds. You don't care about what shape the cloud is in, doesn't matter to you, you're merely noticing. And think about different sensations and think about what quality they have. Is there a discomfort? Is there a pressure? Is there a warmth? Is there a tingling or a buzzing, a numbness? What part of your body do you feel the sensation in? And kind of focus your attention on that part of your body. And then even see if it moves. Does it move to a different spot or move to a different part of your body? And then I want you to think about, so we would have already figured out, for instance, that there isn't a structural underlying problem, that your body is healthy. So I want you to put your attention to that body, that part of your body, and breathe in through your nose. Breathe out through your mouth a little bit longer. And I want you to think about, as you breathe out, that you're breathing into that part of the body specifically. And then I want you to say after me, when thinking about that part of your body, I want you to say, I'm safe. And you can say this. Say, I'm safe. I'm not in danger.
I'm not in danger.
I'm healthy.
I'm healthy.
And I'm okay.
And I'm okay.
And I don't think your unconscious brain could hear. It doesn't have very clear ears and hearing. So I want you to say it again, but I want you to say it a little louder. I'm safe.
I'm safe.
I'm not in danger.
I'm not in danger.
I'm healthy.
I'm healthy.
And I'm okay.
And I'm okay.
And then I want you to focus on your breath again and breathe in through your nose and out through your mouth. And that breath out through your mouth goes into that area of your body. And then I'm going to say it again. And I don't want you to say it out loud this time, but I just want you to repeat it in your head as you're breathing and sending your breath into that healthy, strong area in your body. And say, I'm safe. I'm not in danger. I'm healthy. I'm okay. I'm safe. I'm not in danger. I'm healthy. And I'm okay. And then again, just with the unemotional curiosity, just notice the symptoms. And this is not about making the symptoms go away. It's thinking about actually embracing the symptoms. That this is like a scared child sending danger signals, and you want to just support and love and embrace that. And you can go ahead and open your eyes. How'd that go for everyone?
That's great. Relaxing.
So that's kind of looking into the somatic tracking, which is where we're just noticing our symptoms, our sensations throughout our body. And that's part of what I teach people to do as the pain reprocessing therapy on a regular basis. But doing that is, the point of it is not making the symptoms go away in the moment. It's sort of like if you had broken your arm and it was in a cast for 6 months and you had a little spindly muscle and you needed to get your muscle back, you're going to do your physical therapy exercise every day. And after you do that exercise, you're not then going to look down at your muscle and say, oh, am I strong? Am I back now? No, it takes time. It's going to take months, maybe even longer. Who knows how long it'll take? And so it's just something that we do regularly. And it might even flare it up a little, might even be a little uncomfortable to do our physical therapy exercise. So again, the actual exercise that we're doing regularly is not about the endpoint. It's not, I mean, yes, it's about the endpoint, but it's about the process of getting there over time. The actual exercise is not making it go away in the moment.
That's really helpful. Dr. Kennedy, I was curious, we know that chronic pain affects women more than men. And I was wondering if you can just talk about, for what I've read is people aren't exactly sure why. Of course, we know that oppression and patriarchy can create trauma, and that would explain perhaps some of the higher rates, but also bodies are different, and it's like, it's a little bit, I don't know, it's so complicated. So I'm curious, like, what do you make of that, the differential rates of chronic pain between men and women?
Gosh, I mean, so it's definitely true. And, certainly just in my own practice, I definitely have men, but, vastly more women for sure. And yeah, I don't know specifically why that's the case, but I think that, certainly, different ideas that, probably contributors. I think that, certainly, yes, the underlying sexism of our country puts different pressures and different stresses on women throughout our lives in different ways. I think just like, BIPOC people have different pressures and stresses, because of racism. And I think there's also a lot of social inequities of health because of those underlying stressors and sort of bigotry as well. So I think there's, difference in that. I think that so that's, part of it. I think, certainly the medical community, which I think there's, huge numbers of female physicians at this point. Fortunately, it is definitely a field that huge numbers of women have gone into, fortunately. But I think that still sort of the underlying structure of the medical paradigm is very, sort of, I'm going to say it's still sort of male dominated in that way of thinking and looking at things. I think it's very like where we've come to. I think the problem of why many people don't know about this work, and probably Kathy, you would probably agree, is that, we really separated the mind and the body. And, the mind went to psychiatry and the body went to the rest of the physical doctors, and it's not connected. And previously in medicine, before all this technology and tests and medicines and procedures and surgeries, is that that's what they had. So I think there was less of that, more of an understanding of mind body, but then this just very medicalized focus, which granted there's many great things that we do because of that, but it's really taken away that sort of mind body approach. But I think then, when patients come in and have some symptoms and have emotions in their body and have different things going on, that they are very much, unfortunately, sadly, I mean, it really strikes me deep in my heart that many times the medical industry does blow them off and don't believe them, and say they're a crazy person, or they're histrionic, or whatever it is, and don't get the support and understanding that they need. I think kind of all these different pieces. The other thing I touched on a little bit is that sometimes the personality traits also can lead to this, and personality traits of putting someone else in front of you and not attending to your own body and self and putting others first is actually a huge personality trait that often is related with chronic pain and chronic symptoms. And I think women are really conditioned in this culture to do that. We're the caregivers, and I think even not even just being the caregivers, but just culturally, the ideas around that, I think, is also a piece of it, a strong piece of it. So.
Thank you. I wanted to answer, Kathy had a question. She said, Kent, can you speak about why you chose this topic? Yes, so I got interested in this topic because of my own personal experience. I had chronic pain when I was 22 years old. I developed arm pain that was diagnosed as repetitive stress injury and tendinitis after lifting weights really hard at the gym one day. And I tried all these different things, opioids, I tried physical therapy, and it was getting steadily worse, and I had to drop out of college at the time. And it was just so confusing. I saw so many doctors, and none of them talked about stress or the brain or any of that. They were all just looking at my arm, examining it, and they kind of were like, I don't know. One doctor told me I should eat more to heal my arm pain. So eventually I read this book by Dr. John Sarno called The Mind-Body Prescription. And in that book, he explains that the body has evolved over millions of years to heal and to be resilient. And that really made so much sense to me, and he specifically named my condition as something that he suspected was a mind-body syndrome, which would mean that the brain could actually be switching on my pain and amplifying it and making it worse based on unconscious factors that I wasn't aware of. I didn't know what those factors were, and so I did a bunch of journaling. Anyway, and I was able to make my pain go away the next day. Then the pain moved around my body I got shoulder pain, head pain, chest pain, and that was very educational. Dr. Sarno's term for that is called the symptom imperative, and it's really, really common for people with chronic pain disorders. Most people with chronic pain disorders actually have pain in more than one place. I was unusual in that my pain was just in my arms until it was everywhere else. And then, after journaling about emotions and stuff, I was able to make the pain that was bouncing around go away. And much later, I did more psychotherapy just to deal with anxiety more generally, to be a more kind of emotionally integrated person. But just reading, they call this the book cure. Just reading the book got me better. And for many people, it takes a lot longer, many months of work to recover. But it was just a really eye-opening experience, totally amazing. I learned nothing. I went to a great college and nobody mentioned this. None of the doctors there had any idea about this. And that was in 2004. And sadly, I think there's a little more information and knowledge about it now. There's a lot more information out there, but it hasn't percolated into the medical field nearly as much as you would think. I think Dr. Kennedy, I'm so pleased that she found this work, and we've become friends and talked about this, and she's one of a small handful of physicians that have embraced this work and use it regularly, which is quite surprising to me. that it's so unusual for doctors to take an interest, because we know that it's probably a quarter of doctors' visits are for mind-body syndromes. So it's a huge amount of people that are falling through the cracks, whether it's in the medical offices, but also in psychotherapist offices. Now I'm just on my soapbox anyway. So I wanted to make a film about this and to see, does it really work for people? You know, is it effective long term? Is it a lasting thing? For me, it was lasting, but I didn't know if it would work for other people. So I was just so curious to find out. So yeah, thanks for the question, Kathy. Mary has a question. She says, how useful do you think emotional awareness and expression therapy is, or pain reprocessing therapy, for pain that has a significant structural component? That's questions for you, Dr. Kennedy.
Yeah, it can also be very helpful. And a lot of the chronic pain clinics kind of focus not on the emotional part, but more the pain reprocessing therapy. They do that, like at Kaiser, that our pain psychologists do that. But the thing about them is they actually don't distinguish between structural and non-structural pain, and they're kind of just doing it all. They do understand kind of the brain centralization, that all pain is a signal made from the brain, but it can be helpful for structural pain as well. It doesn't. What I would say is that, though, when there is a significant structural component, we can't turn off that neural circuit and stop it completely. There's just too much information going into the brain at all times. I would also say that I think a lot of times people do think that there's a structural component when actually there's really not, but that's another kind of part of it. And I mean, I guess just one little thing of that is that kind of on that line is that because our medical system doesn't understand this mind-body connection, and we only understand structural reasons for pain or other symptoms, that is what we are focused on, and that is what we then find or say. And so a huge number of tests and studies like MRIs and X-rays show things like arthritis, but the vast majority of arthritis does not cause pain, causes zero pain. But our cultural understanding and medical understanding is that arthritis causes pain. And as a medical doctor, since we're looking for something structural, and then we see arthritis on the test, then we say, oh, arthritis is the reason that you have pain. But the vast majority of people who have arthritis, it's a normal age-related change, and most of it doesn't cause pain.
Yeah, for what it's worth, just to jump onto that, it seems like everyone in our film, we filmed 9 people, they all had been diagnosed with what was considered a structural damage problem. And then Howard examined them, took a careful history, and determined that all of those people did not have a structural problem, and they had a mind-body problem. And so I got diagnosed with a structural problem. I was told I have tendinitis and scar tissue in my arms that was causing my pain. And so what's nice is you don't have to know exactly what's going on at the beginning. You can kind of start to do this work. And if you work with emotion, I'm talking more generally to anyone who's wondering about structural things, like you can start to do the work, and then you can see, does the pain shift and move? Does it go up or down? Things like that. And then that can clarify what portion of your symptoms might be structural and sort of unchanging versus neuroplastic and much more subject to change, movement, going up and down, things like that, based on the therapy. And the therapy usually starts to shake things up. In most people's cases, things start to go. Sometimes pain goes up when you do the therapy for a little while before it goes down. But anyway, so those are some helpful considerations, hopefully. Dr. Kennedy, can we talk a little bit about your experience helping people with long COVID and what that's looked like? I want to first just define long COVID, because it's a new term that's used in different ways. So the way we'll be talking about it tonight is people who don't have, say, like structural damage in their heart or their lungs from a COVID infection, but have sort of like a clear medical workup and then end up in the long COVID clinic and might see a doctor like you. What's your kind of perspective on long COVID?
Yeah, so, even when this started 3 years ago, and I didn't even know about this mind-body work with Dr. Schubiner, as soon as I heard about the sort of long COVID, and I think a lot of other doctors too, but I thought, oh gosh, this is it. This is the next thing that's what our medical community can't define and can't help very well, but is, and again, I didn't really know the terminology and the underlying problem because I hadn't found this work yet, but is part of this chronic condition set. And like fibromyalgia and, chronic headaches and chronic back pain that we don't find a specific reason for, chronic fatigue syndrome. And even though, so I'm the only one that does this specific model of this work in my whole organization of Kaiser Permanente in the Northwest region, but there's lots of other physicians that I talk to, or I've presented this work that really get it and say, oh yeah, that makes so much sense, kind of like I did when I heard it. So I suspected that even 3 years ago, but then when I found this work, I then had the tools and the more details about it and thought, oh, wow, that really makes sense. And I know Dr. Schubiner has successfully treated patients with long COVID, and I have been working, like I'm the physician that sees patients with long COVID in our whole organization, and have been successfully working with people. And again, I always distinguish it as, yeah, I mean, COVID is a terrible disease. I mean, it causes a lot of inflammation, a lot of things, especially, what it was 3 years ago before it sort of morphed and changed and vaccinated and everything. But, and so this is not about, like I was saying, people that have scarring in their lungs and scarring in the heart, which COVID can cause, no doubt. But this is more that subcategory of people who all of the tests have been normal, like they've had every single, MRI of their heart and brain and, everything you can possibly think of. And also their symptoms don't follow what we know that how the body works physiologically. And so when pain moves around, or, they go for 2 months with no symptoms, and then the symptoms come again, or there's dizziness sometimes, but not dizziness another time, or buzzing or numbness or tingling, or, kind of all of these symptoms that again, don't follow the known physiologic nerve pathways, and the tests are all normal. That's the category of long COVID that I work with and successfully treat. And many, many, many patients in this category do have a history of either capital T trauma or little t trauma. And again, it's not everybody, but the more times that the brain has felt unsafe, it primes the brain for then interpreting signals as danger. And so people with fibromyalgia, for instance, I mean, I have a patient who the wind blows on their skin and that is painful. It's not making it up. It's not real. He is experiencing pain because his brain misinterprets that signal as danger, so then sends back down the pain signal. So again, with long COVID, I mean, it is a scary, scary time. We've never been in a pandemic before. The amount of just chronic stress of being in this world, I think, especially even like a year into it or 2 years, I think sometimes we've normalized that stress. And so I think there's this undercurrent of stress that sometimes we're not even really recognizing, but especially in that first year of, oh my gosh, what is this crazy illness and this plague that's just making people drop like flies around our planet, is so much danger. And then to hear about, in the media even, then, oh my gosh, now some people are having the symptoms that were young, healthy people, that the symptoms are going on forever. We don't know what that is. That also causes danger. So, I mean, there's just so many components of danger in the brain. And so So what I've found, and I'm not going to say what I'm saying about long COVID is 100% the truth forever and ever, but with my 20 years of medical experience and working with patients with chronic fatigue and fibromyalgia and lots of different chronic symptoms, and now doing this work and looking at the other people around the country that are doing the work in this model, is it does seem to be fitting that many patients with long COVID, it's because of the mind-body danger signal. And I've successfully been treating people with long COVID who've getting better. In fact, I just saw a woman today who's in her late 30s, and she didn't even have a COVID test. She was sick like in March 2020, probably had COVID, had very, very bad upper respiratory symptoms, and it was terrible. She, and has a history of stressors. She had a terrible, terrible experience. She was at home, couldn't get into the hospital because no one could get in that point unless you were on death's door. And she would get these gripping feeling in this cough and feeling like she couldn't breathe. And she was at home alone with her husband, and her husband was very loving and supportive, but didn't get it, and felt so afraid and alone during this time in 2020. And it's kind of like she has PTSD from it. And really that's how her brain is responding. And so she has brain fog and fatigue. And strangely enough, the fatigue is a danger signal sent down from the brain, like pain, to get us in bed, take us out of the situation. But at any rate, and has had, chest pain and palpitations and ringing in her ears and fatigue and brain fog and I think tingling in her feet. And we've been working together for many months, and little by little is getting better. And, probably, I'd say she's probably 80% better at this point, is that she still gets fatigue, and going upstairs with her groceries, that fatigue that comes upon her kind of overwhelms her, not all the time, some of the time. And but again, doing the emotional work. So she's working on expressive writing. She also is working on, she always puts others first and not herself. So she's working on that, her perfectionism, doing the pain reprocessing therapy, meditation. She's getting a lot better.
Great. That's a great story. I mean, yeah, there's just so many, obviously thousands and millions of people dealing with long COVID. And, these are very much preliminary. We're not sure how many of these people can be helped with mind-body therapies, but we've heard lots of really promising anecdotes. And so it seems important to just say that this is an option out there for people who are interested in looking at long COVID from a different direction. They're doing tons of biomedical investigations of long COVID, but there's not really a known effective remedy, as far as I know, in terms of a pill you can take. And so I kind of think like, may as well try this, since it's worked for many people. If you've tried other things that haven't worked, it can't hurt. It's kind of how I tend to think of it. Well, okay, we're at our hour, or more than an hour. Thanks for staying on late, everybody. Dr. Kennedy, thank you so much for your time. Kathy, thank you so much for having us. This is one of many grassroots screening events that we're going to be doing. So if you want to be involved or do your own screening, reach out to us.